I'm going to re-announce that Palmetto GBA has previously announced that it would record the open meeting and that Palmetto GBA consents to the recording. All right, so I have just started the recording of this open meeting in compliance with CMS. For the record, prior to doing so, I announced that Palmetto GBA would make an audio recording of the open meeting and consented on behalf of Palmetto GBA. All right, with that, we now have a number of speakers we'd like to introduce. We have presentations. The very first one is by Dr. Gary Crump from Rheumatology Associates. And I want to say that we have to be very careful with our time. Each speaker has been allotted 15 minutes, and we have a few remarks at the end, and each person at the end gets about 5 minutes. So with that, Dr. Crump, if you're able to show your slides, we can get started.
Well, I'm a private practice rheumatologist running a very busy group of 5 rheumatologists and 3 nurse practitioners, and very involved with the advocacy for optimal care for patients with rheumatoid arthritis, and have published multiple articles and papers on measuring rheumatoid arthritis and treating to target appropriately, which is the right way to get this disease that has a very high inflammatory burden and a high morbidity and mortality, as well as a very high societal cost to treat these patients optimally. To that end, we employ precision medicine in all ways as best as the new technology emerges and allows us. I'm also a member of United Rheumatology's Medical Policy Committee, which is United Rheumatology is a volunteer organization of about 625 private practicing rheumatologists, and comprises about a quarter of the private practicing rheumatologists in the U.S., and I'm a member of the state rheumatology board here in Kentucky. Let me start by saying that there's been a misconception based on chronology that TNF inhibitors are always the right way to start treating a rheumatoid arthritis patient when their disease is no longer controlled adequately by the oral medications. And in fact, that happens in the majority of cases, that the small molecules that are inexpensive, like methotrexate and leflunomide, are not adequate to control rheumatoid arthritis. And uncontrolled rheumatoid arthritis has cost to the patient in terms of pain, suffering, loss of joint function, and increased mortality, including cardiovascular mortality. Payer-driven models, basically the PBM model, artifactually mandates that we use TNF inhibitors first because they were the first class of drugs that came out. And historically, and more importantly, because those are the drugs that are given the biggest discounts by the PBMs, by the companies to the PBMs, and the rebate system is a whole nother discussion. But we know oftentimes that a patient will spend 3 months trying to get benefit from a drug that they will not benefit from. And there are multiple, approximately 5 other mechanism of action targeted treatments after oral DMARDs, and not all patients respond to TNF inhibitors. And so when we need to go to second line treatments, having a tool like the PRISM RA test allows us to precisely and accurately get to the right choice. It might be a TNF inhibitor if that's what the test dictates. It might not be a TNF inhibitor. There is this disconnect between what payers say we should use next and what we actually should use next. Thankfully, Medicare does not require TNF as the first. You can use whatever drug you think is right. But this test allows us to cut our population according to, do they likely benefit from the TNF inhibitor, or do they likely need an alternative mechanism of action drug? And so it gets us to the right treatment for the patient sooner, and allows us to not expose that patient to an agent to which they will not respond and will potentially suffer side effects or adverse effects from, and certainly will not benefit from disease control for a period of time while they're unsuccessfully trying that new medication. Really, to summarize, and I think there's one more slide that just sort of schematically shows how we use the PRISM test in practice. It gives us a decision point to go with a drug that's the right drug or an alternative drug. And it often can be used even after someone's failed a TNF inhibitor. We can then look and see, instead of repeating another TNF blocker, as sometimes is mandated by certain carriers, we can go right to an alternative MOA to which the patient would have a much higher chance of responding and benefiting. So I think I did it well under my 15 minutes. I'm happy to take any questions.
So most folks are muted, and except for the speakers and the moderators, we have a very large crowd. If there are questions, you can please put them in the chat for this meeting. But typically we don't have a Q&A allowance for this, so thank you so much, Dr. Crump, for your presentation. And again, if folks want to put anything in the chat, that's okay. But at the end of the day, you can take these back perhaps with you and respond, accordingly. Thank you so much for that brief presentation. Please submit written comments in the chat. We are going to move on to Dr. James Moselle, the Medical Director of Rheumatology at the Arthritis and Osteoporosis Center of South Georgia and Internal Medicine Associates of St. Johns County. Dr. Moselle, there we go. I see your slides, so please go ahead when you're ready. Okay, while we're waiting for Dr. Moselle to get started, any comments or questions, please do submit those in writing to Palmetto GBA as part of the comment period. You can submit those comments and questions now. Okay, so what we'll do for the sake of time is move on to the next speaker, and if Dr. Moselle is available in a bit, we'll make sure we circle back to him. So at this point, I would like to go to our next speaker, Dr. Madeline Feldman of Advocacy and Government Affairs.
As you know, my name is Madeline Feldman, and I'm a practicing rheumatologist in New Orleans, Louisiana. I'm also the immediate past president and current vice president of Advocacy and Government Relations for the Coalition of State Rheumatology Organizations, or CSRO. Now, CSRO is comprised of over 40 state and regional professional rheumatology societies whose mission is to advocate for excellence in the field of rheumatology, ensuring access to the highest quality of care for the management of our diseases, which are rheumatologic and musculoskeletal diseases. And our coalition serves primarily the practicing rheumatologist. I'd like to share the perspective of our state and regional societies that are members of CSRO as it relates to Palmetto GBA's proposed local coverage determination under the Molecular Diagnostic Services program titled Molecular Biomarker Testing to Guide Targeted Therapy in Rheumatoid Arthritis. The MolDX program covers several Medicare administrative contractor jurisdictions. Therefore, this proposed LCD is of interest to most of the states and regions that are under our umbrella, the CSRO umbrella. In your proposed LCD, Palmetto GBA has concluded that, quote, clinical validity has not yet been established for molecular biomarker tests that guide targeted therapy in RA. On that basis, Palmetto GBA proposes non-coverage for the emerging technologies in this space. Now, this is disappointing considering that Palmetto GBA's Contractor Advisory Committee subject matter expert, their SME, panelists noted that physicians would welcome predictive tests to guide targeted therapy in RA patients and find them useful if they could help minimize the trial and error approach of current therapy. So even with adherence to the ACR's, the American College of Rheumatology's guideline for treatment of RA, identifying the most effective therapy always seems to involve a try and fail approach. After a patient fails conventional DMARDs or disease-modifying anti-rheumatic drugs, the current clinical evidence doesn't really support initiating a treatment with one biologic or a targeted synthetic DMARD over another. Nevertheless, tumor necrosis factor inhibitors, or what we call TNFs, are the most frequent first-line biologic DMARD prescribed. This is despite the fact that approximately 30 to 40% of patients don't always achieve a meaningful clinical improvement with this particular mechanism of action. Unfortunately, because of insurer requirements, such as in-class cycling, moving to another mechanism of action is often challenging, meaning patients may spend an extended period of time on a therapy that won't work for them. The consequence to the patient is increased disease severity, disability and pain, and not to mention diminished quality of life and difficulties with their ADL's activity of daily living. It should be noted also that sustained high level of disease activity is associated with increased costs not only now, but in the future. Those patients with uncontrolled disease are often required increasing doses of steroids, leading to diabetes, infections, and osteoporosis, as well as a myriad of other well-known side effects. So looking to the future, RA patients with active disease can incur more joint replacements. We know it's a very strong risk for heart attacks and even some malignancies, which will lead to long-term increases in costs. Rheumatologists and our patients are desperate for solutions to this sort of fail first, try and fail paradigm that we've been living under. Molecular biomarker tests are the first tool offering an objective, science-based approach to identifying appropriate medication therapies for RA treatment. Recent studies support the clinical validity and utility, and most rheumatologists and their patients, well, we're all eager to gain access to these precision medicine tools in clinical practice to improve our outcomes. The proposed LCD seems to suggest that such precision tools may never be available for RA patients, but that in any event, the current, approach is good enough. On behalf of our patients, we reject that assertion. Our colleagues in oncology have experienced remarkable growth in the field of genetically driven precision diagnostics and therapies, which has greatly improved not only the survival rates, but also the management of certain cancers. Our patients deserve no less in terms of proactive, data-driven disease management. But we are concerned that the proposed LCD sends the message that investment in this field is simply not worth it. Given the aforementioned, our coalition urges you to establish a local coverage policy and associated payment for the use of molecular biomarker testing to guide targeted therapy in RA, with the following caveats. The ordering and interpretation of molecular biomarker testing in RA should be at the sole discretion of the treating rheumatologist. And as we've always said, patients who are stable on their medicine should not be switched to a different drug or denied coverage of their current medication by the Medicare program, including Medicare Advantage, based on the results of molecular biomarker testing or any other type of utilization management tool. Thank you for considering the feedback of practicing rheumatologists. And if you have any questions, I can be contacted at the email address provided in our formal written response.
Great. Thank you very much for your presentation. And also, we want to be clear that anyone who is speaking may be able to share, but we want to make sure that everyone who's not speaking is both muted and not sharing their screen, please. Let's see if Dr. Moselle is available to provide his presentation. All right, we'll go on and we'll try again to circle back to Dr. Moselle. So the next speaker on our list is Dr. Max Hamburger from United Rheumatology. Dr. Hamburger. The next presentation then is Dr. Solomon of the Arizona Arthritis and Rheumatology Research Center. Dr. Solomon, are you available?
I am available. Can you see me and hear me?
We can, yes, thank you.
Fantastic. Okay, perfect. So let me start by introducing myself. My name is Dr. Nihad Solomon. I'm a medical director at Arizona Arthritis Rheumatology Research Center. I've served in the Phoenix metro area for the past 17 years, actively engaged in clinical trials research for many rheumatic diseases. I currently serve on the Phoenix Rheumatology Association, which is our citywide board. I've been past president, currently the vice president. Also serve on the state coalition here in Arizona. I certainly would like to say I echo what Dr. Crump and Dr. Feldman have already said for sure. I'd like to kind of give you a lens from a slightly different perspective, in as much as our group was actively involved in the clinical trials for the precision medicine studies here with these PRISM RA testing. We know that rheumatoid arthritis is a heterogeneous disease, and we know that patients may respond to some medications and not others. And unfortunately, we don't have the Holy Grail, but the PRISM RA test is one step closer to that precision type medicine, where rather than playing the guessing game, we can use a bit more insight from the distinct biology of the individual patients to assess whether or not they would respond to a TNF drug once there is failure or inadequate response to the traditional disease modifying agents. And unfortunately, over the last 17 years, we've had nothing but constant restrictions, constant jumping through hoops to get the drugs that we believe are appropriate for our patients. As both Dr. Crump and Dr. Feldman have already stated, oftentimes we have to follow formularies that are based on revenue and discounts, and not really in the best interest of our patients. We need, both patients and rheumatologists need precision medicine tools to help tailor therapy based on patients' disease biology, specifically each patient, not just a generalized understanding. And this definitely requires biomarker analysis to predict types of response. There is no perfect biomarker at this point, but we are getting one step closer. And that is my firm belief, after doing the clinical trials research, that PRISM RA is a validated test that helps us get closer to this type of precision medicine. If we wait for the ACR guidelines, which can take anywhere from 5 to 8 years to update, we will be doing a disservice to our patients. Many of us attend the large meetings. We listen to our colleagues, thought leaders out there, and we do know that that there's an ever-changing science when it comes to rheumatology. Selection of even a first-line biologic that's not suitable for a patient's biology will dramatically impact their outcomes and disease progression. We know that we can oftentimes give a drug 3 to 6 months to work, and if we know off the bat they're not going to respond, or their likelihood of response is less than 10%, then there is no sense in trying a therapy like that. And so, again, this is the type of insight that the PRISM RA tool provides for us and for our patients with RA. I'm just going to share with you a case study. 67-year-old female with seropositive RA, Sjogren's syndrome, and osteoporosis, who's had RA since 2003, had been treated with a variety of different therapies, including sulfasalazine, methotrexate, Enbrel, Humira, and Remicade in the early part of the century. In 2020, was treated with Simponi SIP-Q for 4 months. As you can see, this sort of repeated treatment for partially because these were the treatments available, partially because of step edits within various insurances. Initial response lasted for a few months, and then response was lost. Insurance started to dictate repeated TNF trials. When we looked at the PRISM guided therapy, we found that the patient had a high likelihood of non-response. Now, had we had this type of test at the early part of the treatment course, we could have avoided the needless use of one TNF after the next. As a result of having this insight, we switched the patient to Orencia, which is a totally different mechanism of action, and now is doing much better. Her CDAI, which is a disease activity index of rheumatoid arthritis, was 22 initially, and then after 6 months of Orencia was down to 5, which is low disease activity. And so what we see here is that we need to have more information. We need to have more precise information so that after the patient has experienced a failure or an inadequate response, whether it be to methotrexate or conventional DMARD, or even a targeted synthetic DMARD, or even after the first biologic, considering a second TNF in the presence of a test that shows likelihood of non-response is wasting time it's wasting precious time for the patient and potentially worsening their disease state. These are all the references of many of the things that I've spoken about today. Again, I'd like to thank everybody for this time, as well as stress the importance of precision medicine, the fact that in clinical trials, so far we've had dramatic responses and improvement in our ability to manage patients. We've been using this test now in our clinical practice, and have been thrilled with the information that I've gotten and the patient's improvement over time without the guessing game. And with that, I'd like to thank everyone for their time.
Great. Thank you very much, Dr. Solomon. The next speaker on our list is Dr. Priya Reddy of the Florida Society of Rheumatology. Dr. Reddy, are you on the line? Okay, well, we have a few folks to circle back to. Let's see if Dr. Moselle is now available. All right. Dr. Max Hamburger.
I am ready to go. So I'm Max Hamburger. I am 75 years old, which means that I've been in practice for a long, long time. Med school at Albert Einstein, internship and residency at NYU Bellevue. Was remarkably fortunate to be able to train at the National Institutes of Health, where I work both under Mike Frank and Shelley Wolf and Tony Fauci in allergy and infectious disease lab of clinical investigation, where I got a remarkable background in immunology and infectious disease, and then also did a bridge program with John Decker and Paul Plotz and Jack Klippel and others on the arthritis branch, which certified me to sit for the rheumatology boards. And I've been in practice since leaving the NIH in 1979. So I've gotten to see rheumatoid arthritis management evolve remarkably. When I first started in practice, we had prednisone. We had two drugs that barely worked, depenicillamine and gold salts. Then we jumped over to azathioprine, which didn't work very well. And then in the early 80s, we saw the advent of methotrexate. And then in the late 90s, we moved to targeted therapies that were developed based on an understanding of the pathobiology of rheumatoid arthritis. With the advent of the biologics, the outcomes for this disease changed incredibly. And it now becomes very hard to show trainees what bad rheumatoid arthritis can look like, because eventually we can get many patients under good control. But we can't get them all under adequate control to the extent that there are issues that occur to rheumatoids which are quite serious, and rheumatoid arthritis itself rarely is a fatal disease. There are a few things that can happen to rheumatoids which can be fatal, cervical spine disease, but the death rates in rheumatoid arthritis patients are way above their colleagues of similar age because of comorbidities. And one of the consequences of inadequately suppressed chronic inflammation is cardiovascular disease, and that and infection remain very high on the list of causes of death of our patients. So we still are in a situation where a large percentage of patients end up disabled because of the effects of their disease and the comorbidities. And so we have the conflict of far greater efficacy and safety in many of the drugs we use, but as yet, many patients not yet getting onto the right drug at the right time, because we have not had markers that said this is the drug to use for this particular patient. And so we currently go more or less in one of two directions. We go historically, and that is that the TNF inhibitors came out first, so we tend to use those first. We became familiar with them, they had efficacy, so we were impressed. And many managed care companies, and this is critical, have adapted an approach where the first drug has to be a TNF. Sometimes the second drug has to be a TNF. The so-called JAK class cannot be prescribed for patients who have not failed at least 2 TNF inhibitors, even if those aren't the best drug for the patient. And so we need now to look for approaches to the management of rheumatoid arthritis that bring precision medicine capabilities to our toolbox. So dealing with the biology of rheumatoid arthritis, trying to assess disease activity on a molecular basis, and trying to tease about the different phenotypes of rheumatoid arthritis, because what looks like rheumatoid is not always the same thing, particularly when one looks at where the disease actually is, and that is in the synovium, the lining of the joint, where we can find multiple different phenotypes of rheumatoid arthritis that to the outside look very, very similar. So one might say, well, you know, what's wrong with you rheumatologists and what's wrong with your science? You've had these biologics for 25 years and you still don't know what to do. And it is not at all for lack of trying. We have remarkable scientists, Peter Gregerson at the Feinstein at Northwell on Long Island, who's done probably Nobel Prize winning work on the genetics of rheumatoid arthritis. We have Kotz, Spitsalis, and others in Europe looking now at synovial biopsies to see how that plays out. And there have been hundreds and hundreds of papers looking at different biomarkers to see if what's in the blood tells us anything. So at this point, I think my colleagues and I would probably agree that what's in the blood is by no means sufficient. And maybe we're going to get on to looking at synovial biopsies over in the future as a way of guiding. But I think all of us would agree that subjecting every patient with rheumatoid arthritis to a synovial biopsy every time a treatment choice was going to be made would be an invasive procedure that we would prefer not to have to compel our patients to do. None of us are really trained to do that. So there's been an enormous amount of work that has culminated as a first measure in the PRISM-RA test. I think that I first learned about this test, it's got to be 4 or 5 years ago at the Congress of Clinical Rheumatology. So I've watched the company and the science of this mature in a dramatic fashion to the point that now, as others have pointed out, and as the references can speak to, the PRISM-RA test can tell us with a great deal of reliability who will not respond to the TNF inhibitors. And so if we have a 90% likelihood that the result of the PRISM-RA test is correct and that the patient so pointed at will not respond to a TNF inhibitor, we skip that class of drugs and we go on to the other drugs that are there. Now, some people have said, well, maybe the PRISM-RA test just points at patients who don't respond to drugs, but the studies have very clearly shown that is not correct because these patients do respond in an enhanced way to abatacept, which is a T-cell modulator, or tocilizumab and sarilumab, which are inhibitors of IL-6, or to rituximab, which is a B-cell inhibitor, or to the JAKs, which work on intracellular mechanisms. So the response to those drugs is all enriched if one looks at the TNF non-responder, because now we have not wasted 6 months to a year trying to get patients to respond to drugs that they are biologically not programmed to do. Why is it so important to get patients onto the right drug first? Because damage occurs quickly in the first several years. Disability accrues when patients are not on the most effective drug, and the seeds are sown for cardiovascular comorbidities, which again are the comorbidities that eventually lead to the enhanced mortality in a patient with rheumatoid. And as well, the worst 10th decile of patients with rheumatoid arthritis, we know, has a marked increase, a 25-fold increase in the risk of lymphoma. So we need to move our patients from the worst deciles and the worst quartiles into the lowest quartiles and deciles, because those are the patients where the disease will not get them and the comorbidities will not get them. There aren't enough rheumatologists. This is another critical point in looking at wasted time. So in most communities, the wait to see a rheumatologist as a new patient may be 2 to 3 to 4 to 6 months. And in the parts of the country which are more rural, a patient may have a 150-mile drive to get to see a board-certified rheumatologist. And so if you're talking about the western states in particular, like Idaho and Montana and the Dakotas, et cetera, there may be 8 or 10 rheumatologists across the state that's 500 miles wide and 300 miles or 400 miles north to south. So the physicians are overworked. The patients face enormous obstacles in getting care. And the last thing that we want is for a patient to have to travel 150 miles repeatedly because the physician has to examine that patient and the right drug cannot be chosen at the right time. I think the statistics are there that the inadequate supply of rheumatologists probably is at about the 40% or so mark. We have 40% fewer than we need. And so we need to optimize our time. We need to accelerate the patients getting onto the correct drug at the right time. We need to be able to push back at PBM and specialty pharmacy contracted guidelines, which necessitate a TNF inhibitor perhaps first and second before we go to another drug, merely because managed care contracting on behalf of a company manufacturer has struck a deal with a PBM or a specialty pharmacy where no pathway and no science has anything to do with it. Is the PRISM-RA test perfect? No. We need to do better. We need to extend its observations to see what are the predictors of response or non-response to other drugs. The algorithm needs to be trained further, and I'm sure with more work and expanded studies and knowing the scientists who are involved in developing this, the algorithms will be trained further so that the sharpening of the pencil will become more and more fine, and we will know which patient is most likely to respond or not respond to drug A, B, C, and D. And so we can take these biological marvels we have and treat these patients in the most effective way. So I am entirely puzzled when I see how the PRISM-RA test was lumped together with data from, for example, Kos Fatsalis. I know Kos quite well. Kos is a remarkable investigator doing groundbreaking work looking at synovial biopsies. But Kos is years away from being ready. He has thousands of samples or hundreds of samples at least sitting in tissue banks that he has to continue to analyze. Having spent a year and a half working with Kos trying to see if we could help him advance his data, it became very clear that the fruits of his remarkable work and his colleagues in Europe will take another 3 to 5 years to come to the point where they are useful. Will they very likely be enormously useful? Yes. Are they ready for use in the clinic tomorrow? No. Is the PRISM-RA test ready for use in the clinic tomorrow? Yes. And so of the 3 markers that were considered en bloc, I think, that was a strategic mistake. I'm sorry if that offends anybody, but I'm sure nobody made this mistake on purpose. But we lumped together multiple different modalities, which are very, very different and in completely different stages of evolution. There are multiple publications on the PRISM-RA test in peer-reviewed journals that include as authors some of the most prolific and well-known investigators in molecular biology and rheumatology, Viveka Strand, Jeff Curtis, Stan Cohn, the list goes on and on and on. These are some of our, decades in clinical trial researchers who have looked at the data here, and the data has spoken. So as somebody who goes back to the office on Monday, I won't be going back to the office this Monday, just as a side note. I always like to find out what my patients are going through. So this Monday, I've chosen to have my right knee replaced. So when my patients get a knee replaced, I'll be able to say, hey, I did that. So I'm glad to have been able to squeeze this in before I go under the knife on Monday. But when I come back 2 or 3 weeks later, I face 25 to 30 patients every day, 4 to 5 new patients every day. My practice sees 5,000 new patients a year. of whom probably 2,500 have RA. We can do a great job now. We can do a vastly better job with a precision medicine tool. And so I strongly second and stand with my colleagues. I know Dr. Feldman for decades and her dedication to advocacy, the energy that she has put in with no compensation, going to Washington, testifying. All of us are very robust patient advocates because we've watched the damage that can occur, and then we've seen now what the good is that we can do. As a closing remark, why did I go into rheumatology? When I was 13, my father spent a year with a mysterious illness that nobody could decipher. He underwent muscle biopsies. He underwent hundreds and hundreds of different kinds of tests. And after several years, he finally was diagnosed as having ANA positive, rheumatoid factor negative, rheumatoid arthritis. He was a smoker. We now know that was a risk factor. He didn't have the best dental hygiene. We know that was a risk factor. He died at the age of 70 in that 10th decile of lymphoma before we had started to use methotrexate. So I went from having a dad that could toss a ball around to me to a dad who was disabled from a very, very early age. Now I have the opportunity to never have my patients have that happen if I have precision medicine available to me. So in my dad's name and in the name of all of the patients that we all treat, I would strongly urge your organization, which I'm sure is trying to do the right thing, to reconsider and extend authorization to payment for the PRISM-RA test. I went a little fast. I'm sorry. Just wanted to make room for my colleagues.
All right. Thank you very much, Dr. Hamburger. We're going to circle back again. Let's see, is Dr. James Massell on the line? All right. Dr. Priya Reddy. Okay. We'll try again at the very end. So our next speaker is Dr. Robert Levin of Bay Area Rheumatology. Dr. Levin. All right. We'll circle back to you as well. And our last presentation, our last scheduled presentation is by Dr. Sam Asgharian of Cipher Medicine. Dr. Asgharian?
Yes.
We can see you. We know you're here. Yes.
The audio is coming through. And just confirming that my screen is visual.
Yes, we can see it.
Perfect. So we at Cipher are very appreciative of the opportunity to present at the public meeting today. We are, however, understandably disappointed that Palmetto GBA has decided not to cover our test as part of the draft LCD, and look forward to continuing to work with you to further support our coverage application and thereby provide this vital test to Medicare beneficiaries. Very briefly, I want to introduce myself a little further as it relates to both precision diagnostics and clinical coverage. I'm an internist by training and background, and spent the greater part of a decade at Aetna and then subsequently CVS Health, helping run both utilization management and care management, as well as our clinical policy operations that covered both the commercial lives as well as the Medicare Advantage lines of business. I then moved to the world of precision diagnostics and screening solutions as Chief Medical Officer of Thrive Earlier Detection, helping that company achieve a formal protocol agreement letter with the FDA, as well as launch an LDT pathway for its machine learning classifier-based blood test detecting cancer. That was incorporated and integrated into the Exact Sciences pipeline, where I helped build out a further fleshed out product roadmap for earlier detection and screening solutions. I'm now leading similar efforts here at Cipher Medicine, and my goal as a practicing and then as a non-practicing physician has always been to bring more preventive and curative care delivery solutions to healthcare so that physicians can spend time detecting and mitigating the risks and adverse events that come from diseases and disorders such as rheumatoid arthritis. Towards that end today, I'll be providing a brief introduction and background to our company and our blood test PRISM-RA, which has continued to gain adoption by the rheumatology community, as noted today, in parallel with the progression and continuation of the studies that use our precision medicine test to first previously establish and now further confirm the validity and utility of the test. I will conclude with similar sentiments as those shared by the esteemed specialists at this meeting regarding the need for this test within the rheumatology specialty. So our company, Cipher Medicine, is focused on providing physicians like those today with the right tools and solutions to deliver precision-based care to their patients. Doing so helps achieve the critical aims of improved outcomes, lowered costs, and more efficient healthcare delivery, similar to what we've seen occur in the diagnosis and treatment of cancer patients today. We combine the capabilities of machine learning with the advancements in next-generation sequencing to help physicians learn more about the underlying physiology of their patients' autoimmune diseases. The test we're discussing today is already experiencing large-scale adoption across the country. Throughout the United States, physicians and their practices as a whole have been ordering our test given its utility and necessity in the care of patients. Many of those patients are and have been covered by Medicare, and as such, our goal is to continue to work collaboratively to improve access and coverage of the test as we are doing today. By providing an objective data point to rheumatologists, our test captures and conveys information about the disease pathology not capable of being measured by current metrics or exam techniques. Patients can then receive an appropriate treatment sooner and with more robust outcome results. This is the most important area that I want to cover today, right? So what we really have been aspiring to do is build this body of evidence, this clinical world of studies that have shown validity and utility. Our test, the intended use is for both naive and previously exposed to tumor necrosis factor inhibitor therapy patients. We've been seeing the study findings capture improved outcomes across the patient populations in increasingly greater numbers. We have developed an extensive body of evidence that depicts the value of the test and the objectives we achieve when it comes to predicting response to TNFIs and the overall improvement to outcomes that come with it. Our test has been validated both retrospectively across approximately 600 patient samples and prospectively across another approximately 1,500 patient samples. As you can see on this slide, we have three groups of clinical utility papers, moving an increasing number of N from 85 to 478. What's important for me to note is we really rarely ever drop out patients after they've enrolled due to the low invasiveness of our test, as well as just the simple need to have them follow up with their rheumatologist who continues to manage their care predominantly as the primary quarterback. The patients stay enrolled. What you see here is the typical maturation of outcomes data. At the very beginning of clinical utility paper number 1 in December, we had fewer patients achieve six-month outcomes data than they did in April when clinical utility paper number 2 was published, than they do now when clinical utility number 3 has been pending publication. Knowing this, we've always worked closely to further validate the endpoints that these N numbers show. So when we originally published paper number 1, we used ACR 50 as our endpoint, and we showed considerable improvement in the cohort that received our test, and care was followed based on the results of the test when it came to achieving ACR 50 in a 6-month period. We heard loud and clear from this same physician community who has spoken today that ACR 50 isn't always the best metric used in clinical practice. They advocated that we look at CDAI scores and measure a primary endpoint using CDAI. The second paper did that and concluded a 1.8 times greater reduction in overall CDAI score. As noted by Dr. Solomon, guideline-based care focuses on treat to target, not simply a reduction in the metric, but moving those patients from a category of high and moderate disease to a category of low disease activity and remission. As noted by Dr. Hamburger, our goal is to really allow for the rheumatologist to focus on the sickest patients and to triage them appropriately as they come to the clinic. The third paper, which will be published very shortly, looks at that as compared to standard of care and showed that using precision-based medicine and our test, PRISM-RA, resulted in up to 2.6 times greater odds of receiving or reaching that low disease activity and remission state. As a quick side note, I want to also note that it's important for us to make sure that this focuses on the patients who are eligible and receive Medicare, looking only at the 65 and up eligibility criteria, not the disability eligibility criteria. In our first paper, I'm happy to report that of that 85, 19 of them were 65 and older and therefore eligible for Medicare. Of the 274 in the second paper, 71 were 65 and older and therefore eligible for Medicare. And in the third paper of that 478, 178 were eligible. Now, those aren't simply demographics, that's just based on age eligibility. As we delve deeper into it, we know that this disease predominantly impacts women more than it does men. The majority of these Medicare eligible patients were women. In fact, of the 19 in the first paper, 16 were women. Of the 71 in the second paper, 59 were female. And of the 478 in the third paper, 143 were female. And I'm also happy to report that of the total Medicare eligible by age only population within our studies, approximately 20% were of a minority status. That further shows to us that this test is being adopted and continues to see great integration, not just in clinical practice, but across the wide spectrum of individuals who are afflicted by rheumatoid arthritis, especially across our heterogeneous country and the demographics that we see within the United States. Now, I'd like to spend a little bit of time, but not too much, on each one of those papers' primary endpoints. On the first scenario, I'd like to specifically start with what we believe to be a key misinterpretation of a result related to the utility of the test. On the first paper, what we noted and what you see at the bottom of the slide is that Palmetto GBA's rationale for non-coverage in the determination of this test said that, for example, in the molecular signature response classifier studies, the response to alt-MOAs in the predicted non-response group should have exceeded that observed with tumor necrosis factor inhibitors at baseline, but it did not. We were surprised at this and we consider it a misinterpretation because this is truly one of the primary and secondary endpoints of the paper. As we brought here, the predicted non-responder group that still received tumor necrosis factor inhibitor, because as Dr. Feldman pointed out, the rheumatologist is still the quarterback in the care of these patients and makes the final call as to what therapy they receive. Our job was to report the outcomes and show that the outcomes are improved when they receive the therapy that our test may better indicate. The absolute baseline CDAI score for this population was 30.8 over the average of the group. For the alt-MOA receiving group, that again received a predicted non-response signal, it was very close, which we expected it to be at 32.4. But when we look at the results between the two, the primary endpoint again was ACR. Only 10% of those that were predicted non-responders that received tumor necrosis factor inhibitor therapy achieved an ACR at 6 months. More than threefold that patient population at 34.8% achieved the ACR at 50 at 6 months on an alt mechanism of action drug. If we simply look at CDAI as well, which we did in this paper and we reported it out as a supplemental or additional endpoint, the group that received the alt-MOA experienced a 1.8-fold greater improvement in CDAI scores than patients with a molecular signature treated with that tumor necrosis factor inhibitor. We believe this is critically important because the potential misinterpretation of these data points led to a train of logic used to argue against the value of the PRISM-RA test in comparison with current standards of care, which we found surprising because the evidence we have been generating has established the exact opposite conclusion. In further support of that, as you see our second paper's primary endpoint, when we look now at CDAI, we saw that regardless of whether it was tumor necrosis factor inhibitor therapy or an alt mechanism of action, when the test results were followed in clinical practice, the patients achieved better outcomes, and they're achieving them faster than they would through the traditional and empirical and sequential or trial and error approach to rheumatoid arthritis treatment and therapy. And we also have covered this with Palmetto GBA, and I believe secondary just to the fact that we know there's a need to stop reviewing at some point in time. This paper was not part of the overall decision. We will resubmit this through the formal comment period, and we look forward to it being incorporated as part of the review into the final draft coverage decision. What you see here ultimately is in this group where you had a predicted non-responder that again received the tumor necrosis factor inhibitor therapy, their CDAI reduction over the course of 6 months was lower than the group that did not have that signal that still received tumor necrosis factor inhibitor. So again, when the physician has a more confident ability to prescribe that same drug, their patients do better knowing that the test result was an objective data point that allowed them to prescribe that drug. When they receive a different drug, when there's a significant signal of non-response, again, those patients do significantly better, statistically significant in a paper that was published in a peer-reviewed standpoint, again, with a higher N number where we did see a fair number of Medicare eligible patients. In addition to this paper, we'll also be submitting for consideration in this formal comment period our next paper, which now stops looking at simply a comparison or a comparator of our test when it's followed and when it's not in clinical practice, but actually compares our test to a standard of care control arm in a very larger, higher number of an N value. When we looked at this and we looked specifically at this row, again, from a treat to target standpoint, a statistically significant group of patients were reaching low disease activity or remission when the molecular signature response classifier test was used as part of their therapy and treatment than when the traditional trial and error approach to treatment was used. This again occurs in a very short period of time. In 180 days of a readout, these patients are getting to low disease and remission. So again, to Dr. Hamburger's point, that allows the specialist to spend far more time seeing new patients or seeing their patients faster, because now you have more security knowing that your patients are well managed and on a maintenance mode. That's our ultimate goal. So while we will be submitting more comments and more papers throughout in the formal comment submission period, I just want to spend a little bit more time in the interest of time today on the validity and utility of the test, as well as its medical necessity. After listening to and rereading the transcript from the Contractor Advisory Committee meeting on December 7th of last year, we at Cipher Medicine were surprised to hear that the contractor believes that tools and metrics are already available to practicing physicians, and that the utilization of hypothetical combinations of these metrics and values would provide predictive power and improved outcomes comparable to that of our test. The physicians and advocacy groups that have previously supported our coverage application have continued to provide their expert viewpoint, refuting this belief. We additionally have published studies and conducted analyses as our evidence generation has matured, which shows that clinical features alone do not provide the same capabilities, efficiencies, and improved outcomes as genomic features that capture the underlying pathology of this complicated disease. The combination, of course, is what works best, as it allows the physician to incorporate all available information based on the patient's presentation to prescribe the most effective treatment targeting the underlying disease pathology. These studies and subsequent analyses will be submitted to Palmetto GBA during this open comment period, and we are looking forward to discussing them after this blackout period concludes. Lastly, as a physician myself, I fully understand the value of these tests and the need to provide coverage for them so that they can be made available to patients. As Dr. Feldman noted, as a previous primary care provider and someone that advocates for preventive medicine, knowing that you have proactive data-based disease management is one of the highest forms of practice that a physician has at his or her available disposal, especially for a disease where we know that today RA patients suffer from debilitation due to irreversible joint damage. Sometimes it's treated with the most invasive of surgeries and procedures, ultimately still leading to permanent handicaps and a decreased quality of life, even when these patients adhere to and stay compliant with measurements. With Prism RA, patients can avoid treatment they are unlikely to respond from and get on the right treatment sooner. I believe that members from that same Contractor Advisory Committee from December 7th, along with these additional providers, experts, caretakers, and specialists, have provided facts, data, and evidence in support of coverage for Prism RA, as well as other molecular signature response classifier tests, as they have been throughout this review period. As such, I will now conclude our presentation and defer to the rest of the presenters for their perspectives, experiences, and conclusions. Thank you again to Palmetto GBA on behalf of Cipher Medicine for the opportunity to present today.
Great. Thank you, Dr. Askarian, for your presentation. We do have still a few of our speakers, our planned speakers that we're not able to present. We want to see if you are now on the line. Dr. James Moselle. All right. Dr. Priya Reddy. Okay. Dr. Robert Levin?
Yes, I'm here.
I see you there. Perfect. Okay, wonderful. Dr. Robert Levin of Bay Area Rheumatology, please go ahead with your presentation.
Thank you very much, and I really appreciate the opportunity to speak with you today on something that I really feel is an advance in rheumatology and would really be a shame if it was not something that was available to Medicare beneficiaries. Let me pull up my slides and I'll be right with you. First slide is just about me. I am a practicing rheumatologist in Clearwater, Florida, and I've been here in practice for over 30 years. I'm a board certified rheumatologist, and I've got several faculty appointments, including an assistant affiliate professor of medicine for the family practice, as well as residency and rheumatology fellowship, as well at the University of South Florida. I am a medical director doing clinical research, and I've been involved in doing clinical trials with PRISM-RA. I'm a fellow member of the American College of Rheumatology and American College of Physicians. I am on the board of directors of the Coalition of State Rheumatology Organization, Florida Society of Rheumatology, and I'm on the board of directors of our medical supergroup, the American Arthritis and Rheumatology Associates. I have wealth of experience utilizing this test. It has been something that I've tried to incorporate into my practice, and I have found that it's been incredibly useful. Therapy selection for patients with RA is often driven by payer criteria and rebates. This really, in terms of Medicare beneficiaries, applies much more to Medicare Part D than to Medicare Part B, where in Medicare Part B, beneficiaries, we have the option to choose any covered medication as long as we're following the LCDs for the drugs that are being given. So we have the opportunity to pick what we think is best for the patient using shared decision making. And I think that that's obviously the ideal for us, is that we really like to have the opportunity to figure out what's best for our patients. But honestly, when payer criteria come in, a lot of it is driven by finances and not necessarily the patient or the patient and the doctor feel are most important. Clinical guidelines do not recommend one biologic class over another. And simply put, I think in the last presentation, we saw that without having a test like PRISM-RA, we really can't figure out which drug might be best, just looking at the clinical trials and trying to line them up side by side. Obviously, you can't compare drug efficacy or drug safety formally looking at patients that are enrolled in different studies. But we do that, and we try to pick out, based on the patient's individual characteristics, what might be best. And so the guidelines have been unable to come up with a recommendation for one, because all of the efficacy data and pretty much for the safety information looks fairly similar in the clinical trials of the drugs. So there are a number of drug class options with comparable efficacies in rheumatoid arthritis, the most common class being the TNF inhibitors, which we, by habit, because they've been on the market the longest, and also based on drug formularies, we tend to pick first. But that does not necessarily mean that that's the best drug for that individual patient. And the PRISM-RA test, as I think was demonstrated very clearly in the last presentation, shows that if we can use a test that actually will help us predict lack of response to a TNF inhibitor, that's something that's incredibly valuable, because we know that in rheumatoid arthritis, getting a patient to low disease activity and remission earlier using the right treatments will lead to better outcomes, less joint damage, better function, and an overall increase in patient satisfaction. Patients who do not respond to their initial targeted therapy are less likely to respond to subsequent lines of targeted therapy. And that's especially true if the patient does not change the mechanism of action of the drug that they're using. So if we've gone to targeted therapy and we start with a TNF inhibitor, and we then are obligated to use a second TNF inhibitor, which is commonly seen in drug formularies by insurers in Medicare Part D, then we are less likely to see a good response than if a patient changes their mechanism of action. Unfortunately, we don't always have that choice because, again, it's payer-driven and it's driven by finances and rebates rather than efficacy, safety, and what might be best for that individual patient. So there are a lack prior to the PRISM RA, there's been a lack of tools to guide effective RA treatments. Rheumatologists don't have tools that are able to tell us which targeted therapy our patients will not respond well to. And you can't, I'm sorry, but you cannot use rheumatoid factor, CCP antibody, SED rate, CRP, joint counts, any other metric that we have. Do not discriminate which type of therapy, which mechanism of action might be the best for that individual. And prior to the development and approval of PRISM RA, we have not had such a tool. I think that the data that's been presented, that was presented during the last talk, clearly showed that using that using the PRISM RA, we are much more likely to get a favorable response initially, which is so important for our patients. Biomarkers are required in order to predict response in RA. And that's RA is a heterogeneous disease, and some patients respond to certain drugs and some don't. And I think that PRISM RA really takes that into account, the 23 different pieces of information, whether they're biologic, genetic information, or their clinical information. When that's all combined and we come out with a PRISM RA score, that really helps us guide who is more likely or less likely to respond to a TNF inhibitor therapy, which, like I said, is the most commonly used biologic class and oftentimes the drug that is used first. If I know that a patient has a low likelihood of responding to a TNF inhibitor by the PRISM RA test, then I am likely I'm almost certainly going to choose a different mechanism of action in that patient, because that patient's more likely to respond to something else, and the TNF inhibitor is less likely to be effective. And like I said, that's an outcome that that both the physicians, the medical providers, and the patients are looking for. We need to get patients on the right drug early in their diagnosis to reach treat-to-target goals of low disease activity and remission, and prevent debilitating, often irreversible long-term damage for the patient. We know that long-term damage to the joints occurs early in the course of the disease, and getting the patient on effective therapy that is effective for that patient is the best way to prevent damage and ultimately lead to the best outcome possible. And PRISM RA is a critical tool that we have that's available right now that should be covered. That's something that can help us achieve that goal. Repeated medication changes also expose our patients to significant adverse events with limited benefit. And all I can say about that is that there are studies out there showing that when we have to change drugs, especially switch patients off of medications that are effective, there are increased adverse events, many more doctor visits, many more hospitalizations, many more complications, and that's based on formulary changes and things that really can negatively impact our patients. And so we need a tool to tailor therapy based on the patient's individual disease biology for rheumatoid arthritis. And I think that PRISM RA really speaks to that, really has achieved the goal. And with the increased amount of data that's been published and is to be published in terms of the large-scale clinical trials that have been read out and are in process, I think that the more data that comes out, the stronger and the better this test looks. With that, I have a list of references on this slide. I'll conclude. Thank you very much for your attention. I'd be happy to answer any questions.
Thank you, Dr. Levin. As we mentioned earlier, we don't have the opportunity for a Q&A, but everyone is welcome to submit their comments to Palmetto GBA as part of the comment period. I believe Dr. Priya Reddy has joined. Wonderful. So Dr. Priya Reddy of the Florida Society for Rheumatology, please go ahead with your presentation.
Okay, wonderful. Thank you all for being here and allowing me the opportunity to speak. I'm just going to share my slides. Let me know if you're able to see my slides.
Yes, we see them.
Okay, wonderful. So my name is Priya Reddy. I'm a practicing rheumatologist in Riverview, Florida. And for those of you who are not familiar, this is in Hillsborough County in the greater Tampa Bay area. I wear a lot of different hats professionally. I'm an assistant professor in the Division of Rheumatology at USF Brandon Regional Hospital. I am also on the board of directors with Dr. Levin for the American Arthritis Rheumatology Associates and Secretary Treasurer of the Association of Women in Rheumatology. And I want to today really sort of focus on the most important hat that I wear, which is providing patients with diagnosis and treatment and providing the best care that I can for my patients, because that really is what drives all of the other professional goals that I have, is to provide them with a scientific basis for their diagnosis and their treatment, as well as optimize the patient journey of chronic illness, which in rheumatology encompasses diseases that are really poorly understood on the best of days. They are underdiagnosed as a result of that, and they're undertreated as a result of that. And today I'm going to focus obviously on rheumatoid arthritis, and I'm going to talk about how the PRISM RA test affects and improves specifically that under treatment aspect of our diseases. So we really do need precision medicine tools in therapy selection for our patients who have rheumatoid arthritis. This is really important. The time is now to use the tools and the science to move forward in rheumatoid arthritis and to allow us to use these tools to optimize this patient journey. Remember that when a patient is diagnosed with rheumatoid arthritis, this is for the rest of their life. And when I told you earlier about the misdiagnosis, this is someone that we see in our clinic who is a patient who's been struggling with joint pain, disability, a lot of stiffness, possibly already damage to their joints because it's taken a really long time for them to get this diagnosis. So when they come and see us, it's really important for us to treat them and treat them on target with the right tools quickly. And the ACR, American College of Rheumatology, really doesn't specify that we need to do one targeted therapy over another one once patient has tried our gold standard, which is methotrexate. And typically patients who we move on past methotrexate therapy are people who are in moderate to severe rheumatoid arthritis disease activity. So these are people that are quite active with disease and carry a large disease burden already. We do know that if they fail that first targeted therapy, they're less likely to respond to the next targeted therapy. This has really been shown quite clearly in the literature, and Dr. Levin alluded to that earlier in his talk. And what winds up happening is that we have this trial and error approach where we look at specific therapies, we select doses, we change until we find that right fit. And meanwhile, the patient is experiencing a lot of side effects of different medications that probably were not the right choice for that patient. And they have cycled through medications while disease is active and ongoing. So PRISM RA really fills this gap here. And what we've seen in studies done so far is that patients who were prescribed a treatment that was aligned with that PRISM RA result had a significant improvement in their clinical response rate. And this was more than 3 times higher when therapy was not aligned with the test results. And what we know is, as I said earlier, is that if patients have an inadequate response to their initial targeted immunomodulator, they are less likely to respond to the next one. And as I said, this ongoing disease activity debilitation is obviously going to increase healthcare utilization, medical costs, and indirect costs due to patient being unable to work and work loss. So just to summarize, what I want to highlight again is that these are patients who have RA, moderate to severe. They have ongoing disease activity. They've tried methotrexate. What does this mean to the patient? They cannot take care of their families. They cannot take care of themselves, so they need their family to take care of them. They cannot work and continue to be employed. And if we think about this one person and that burden of disease for however long it takes to reach targeted therapy, we're really seeing a much larger economic burden to the community. And not to mention that this ongoing disease activity causes inflammation and active destruction of their joints, which then obviously only leads to more disability. So if this patient is able to get a Prism-RA test and we're able to align the treatment selection with that result, what happens? We get a much quicker reduction in disease activity, which then is obviously going to improve these symptoms that the patient is having, not only of pain and destruction of the joints and disabling inability to use the joint, but also fatigue and stress. You can imagine that someone going through this is experiencing a considerable amount of fatigue and stress. And now this patient has an appropriate targeted therapy based on that Prism-RA result. They can complete ADLs, care for their family, return to work. And obviously we're able to really put out this fire, so to speak, or at least lessen the flames of the fire of inflammation and reduce their inflammatory burden. So this is clearly a test that's based in science. And as physicians, we want to utilize science to improve the patient journey and provide better care for our patients. So thank you very much for your time. And I so appreciate you giving me the opportunity to speak. Thank you.
Thank you, Dr. Reddy, for your presentation. All right, so we are now going to circle back once again and see if Dr. Moselle has joined. Dr. James Moselle. All right. With that, that actually concludes the formal presentations that we have received, but we do have a number of physicians who have reached out to provide a few comments. And so we have 5 minutes allotted per presenter here. So we have first on our list, these were latecomers and didn't make the agenda. Dr. Gwenesta Melton, are you on the line?
I'm on the line. Can you hear me?
Yes, we can hear you.
Thank you.
Thank you. Please go ahead with your discussion.
My name is Dr. Gwenesta Melton. I am the current Vice President and Co-Chair of Advocacy for the Association of Women in Rheumatology, also known as AWARE. I've been a practicing rheumatologist for 34 years in North Carolina. AWARE is dedicated to promoting the science and practice of rheumatology, fostering the advancement and education of women in rheumatology, and advocating access to the highest quality health care and management of patients with rheumatic diseases. Our rheumatology members across the country, including members across the globe in over 30 countries, are committed in helping find a solution to the continuous rise of out-of-pocket costs and access challenges for our patients. This includes supporting new technologies like precision medicine. AWARE was disappointed to learn that Palmetto GBA determined that clinical validity was not yet proven for rheumatoid arthritis. These innovative tests have begun to allow members of AWARE and other rheumatologists to better identify the right medication at the right time. As you know, trying and failing medications can have a lasting impact on patients' disease stability and an association with increased costs to the healthcare system. Even in the exciting therapeutic era of biologic disease-modifying anti-rheumatic drugs, most patients fail to achieve the desired high-level response equivalent to low disease activity or remission, and almost 40% of all patients treated with biologic DMARDs do not even experience minimally acceptable improvement. This means individual patients are treated sequentially with different drugs, selected using little mechanistic rationale, as my colleagues have alluded, consequently leading to increased costs, unnecessary toxicity, and suboptimal effectiveness. Knowing the struggle to find the right medication at the right time for RA patients is more important than ever to consider the precision medicine data in support of predictive testing in RA. This would include all supporting clinical evidence that Palmetto GBA may not have taken into consideration before issuing the negative determination. AWARE is committed in working with Palmetto GBA and helping provide rheumatologists with a new innovative tool that saves patients from the trial and fail gauntlet while providing an overall cost savings to the healthcare system. We urge you to implement a policy that provides for access and reimbursement for molecular biomarker testing to guide targeted therapy in RA. We appreciate your consideration of our viewpoints and encourage you to contact us directly should you have any questions. And thank you for my ability to share these comments.
Thank you, Dr. Melton, for your comments. Next on our list, we have Dr. Greg Niemer of Low Country Rheumatology. Dr. Niemer?
Yes. Thank you very much for allowing me to be able to speak. I appreciate it. I want to thank all of my colleagues who've already spoken and made some very good points. I'll try to be focused. I'm a rheumatologist. I've been in practice for over 20 years in Charleston, South Carolina. I've served on our state rheumatology society board, both on the education and the advocacy side. I'm part of a large single specialty rheumatology practice and also a large single specialty group purchasing organization, and have had the privilege of taking care of, 1,000 rheumatoid patients over the past 20 years. And the importance of looking at this test, I think, can't be overstated. And we've done a fantastic job within rheumatology field over the past 20 years of aggressively treating our rheumatoid patients to the point that through getting them on medications such as methotrexate and then moving to biologics and using treat to target, we're able to achieve remission and low disease activity in a large percentage of our patients. Our challenge continues to be that first decision as far as which biologic to use. And this is very important because we know from data that window for achieving low disease activity or remission in our patients is not long. If you look at data, if patients have active disease for 6 to 12 months, then their chances of receiving or achieving low disease activity or remission drop considerably. So this is something that we need to understand, that our decision from the beginning is not something that can just be made up for as time goes on. Sometimes these levels of disease activity can't be recaptured. And so if we start a patient on a biologic, we give them a trial, which usually takes 3 months. Then we go to a second biologic. That trial takes 3 months. Oftentimes we have to stay within the TNF blocker class for that second medication. By the time you go through your 2 trials, you're already halfway through that window of having the best opportunity to achieve low disease activity or remission for our patients. And that's why it is so vital that we make the decision from the beginning, the best decision based upon objective measures, for which to this date we have not had. So this gives us that first opportunity for true precision medicine within our rheumatoid arthritis treatment algorithm. it's been argued that this treatment or this test may not be medically necessary, but it is a medical necessity that we prevent unnecessary side effects for our patients on treatments where there is foreknowledge that the efficacy of that drug may be suspect. So this is something that we need to take into account and do our very best to make sure that we're making the right decision initially with which medication is chosen. And you know, the cost of the test in comparison to long-term consequences of active rheumatoid arthritis, as some of my colleagues have already have described, there's no comparison between those two costs, and a lot of these long-term complications are unnecessary and preventable if we are able to start the right medication as soon as possible. And thankfully, now we have tests such as Prismore that allow us the opportunity to be able to get our patients on the right medication in a more timely fashion. So thank you very much for allowing us the opportunity to share our opinions and explanation of why we think that this test is so important to be available to us.
Thank you, Dr. Niemer, for your comments. Next, we have Dr. Joseph Hupstetter of Arthritis Associates. Hi, Dr. Hupstetter. Hopefully you can hear me.
I can.
Oh, wonderful. Okay, well, you have a few minutes for your comments. Thank you for joining.
Thank you so much. And I know the people on the panel are just sick of hearing from rheumatologists, and they're just going, oh no, another rheumatologist. I haven't heard from this many rheumatologists in a long time. But I'm going to give you a little bit about my perspective. I'm a practicing rheumatologist in Hickson, Tennessee, which is a suburb of Chattanooga. And I'm more of a bottom line kind of person. I know you've heard a lot of science about this, and to be perfectly honest, I don't think I'm qualified to address some of the scientific issues around the test. But I am kind of a bottom line person, and I treat patients 5 days a week in our office here. So that when I see a patient with rheumatoid arthritis, I try to quickly and as accurately as possible make the diagnosis and then initiate treatment. And as you've heard before, methotrexate's the standard treatment that we start people on, and we do that in most people without too many difficulties. And most people tolerate it pretty well, although not everybody responds. And that's where we get into some of the issues, because when they don't respond or don't tolerate methotrexate, then we're kind of at a dilemma and a crossroads about which therapy we choose. And we've looked at this for a long time. In fact, there's a test that Medicare approves for doing twice a year called a Vectra DA that actually predicts how people may do and tells how active their disease is. And one of the interesting things about this is it actually checks two separate cytokines. One of them is anti-TNF and the other one is IL-6. And you think, wow, those people that have high TNF levels, they should respond to a TNF medicine. And it's absolutely not the case. And you think, well, gee, these IL-6 levels are great. We've got drugs that really can suppress IL-6. If they're high, that's really what's driving their inflammation. That's what you need to choose. And it's not the case. Those do not correlate with a person's response to either one of those mechanisms of action. So with this new test that's available, it improves the likelihood for me being able to pick the right drug for the right patient. It's not a perfect test. It's not 100%, but it does kind of guide our therapy so that as quickly as possible, I can get the right drug to the right patient. And I think that's important in our patients that have really active rheumatoid arthritis, because for those of you that don't treat this illness, I would think that I would give you an analogy of, you know, your house gets on fire. It's a kitchen fire. And if you can catch it as a kitchen fire and throw a lid on the skillet, you muffle the fire is out, there's not a lot of damage to the house, everything's cool, you're happy. But if you don't get that fire put out and the fire spreads to the rest of the kitchen and the living room and the dining room, you have to get the fire trucks in, you get the fire companies in, it takes a lot of water and there's a lot of damage to the house, but eventually you get the fire put out. And what we're trying to accomplish with this idea of precision medicine is getting the right drug to the right patient as expeditiously as possible so that there's less damage to the patient. I really think that there's some data to show that as quickly as you can treat these patients effectively, then it actually costs less for the whole system. So, you know, it's not a test that I'm going to use on all my rheumatoids. The majority of my rheumatoids may not even need this test because they'll respond to methotrexate, or they will they don't have a TNF as they have problems with taking a TNF. They have chronic infections, so you may not be even able to use biologics in these patients. But I think we really need access to this tool. You don't have to. You can actually have an LCD for this, so you can look at which patients you may want to use this in, and I'm okay with that. I'm a member of the CAC for Tennessee, and I'll help with crafting an LCD so that the test is not abused. But I really want to have access to this test so it'll help guide therapy for my patients, and I'll shut up. Thank you for listening.
Thank you, Dr. Hofstetter, for your comments. Next, we have Dr. Firas Kassab from South Charlotte Rheumatology. I believe I saw you a moment ago. Perfect. Thank you. Welcome.
Hello. Thank you for allowing me to speak. I'm sorry, I just finished with a patient. I'm getting my comments here on the screen ready. And I'm sorry I missed the rest of the meeting. I had a busy schedule this afternoon. My name is Dr. Firas Kassab with South Charlotte Rheumatology. Thank you for providing me the time to speak today. I'm providing comments today on behalf of the North Carolina Rheumatology Association, or NCRA. I'm an independent community-based rheumatologist in Charlotte, North Carolina, and currently serve as a board member at NCRA and have served in the past as a president of the organization. I have worked in rheumatology for over 15 years. NCRA's mission is to promote the science and practice of rheumatology and advocate access to the highest quality healthcare and management of patients with rheumatic diseases. So with regards to predictive biomarker tests, NCRA fully supports the future use of these precision medicine tools as important tools to optimize the care of our patients with rheumatic diseases. NCRA feels that the clinical data presented to demonstrate the clinical utility of the tests is currently sufficient to allow the use of these tests in clinical practice, and further delay is really not warranted or necessary. Hopefully those tools will continue to improve with time, but they are desperately needed now to improve the quality of care, and the clinical evidence presented to support this is more than sufficient in our opinion. Each trial of a TNF inhibitor in a patient who is unlikely to respond is going to delay bringing the disease activity down and really increases the risk of negative outcomes, let alone the potential side effects or risks associated with these medications. So it really would be beneficial if a test can give a clinically validated prediction of response of this class of drugs. Even if this test changes the treatment algorithm for some and not all of the patients, these would be huge advantages, both in terms of clinical outcomes and for cost savings. The fail first methodology, which is the current imposed method of finding the appropriate treatment for RA, is not really appropriate anymore. Where time versus cost is a significant issue in controlling disease activity, predictive tests based on available data provide rheumatologists with an option to bypass these failed first approaches. Furthermore, based on the review described in the proposed LCD of the December 21st, 2021, the CAC meeting said that the subject matter expert panelists commented that insurance companies often require, and I'm quoting here, insurance companies often require a trial of 1 to 2 TNF inhibitors before covering other targeted therapies. And there was consensus that the requirement by the insurance companies for patients to fail multiple TNFs inhibitors prior to paying for an alternative targeted therapy is unreasonable. This policy really doesn't have anything to do with the efficacy of these medications, and more to do with driving patients to the drugs with higher rebates. We all know that. Although this is not completely related to today's discussion, which we all agree should focus on the value of the tests themselves, it is important to recognize that the positive impact of these tests will have for the patient access and outcome will also actually impact cost reduction. In conclusion, the North Carolina Rheumatology Association fully supports the use of predictive biomarker tests and urges MoIDX to generate an LCD policy and allow coverage for these tests. I'm available to answer any questions or concerns by phone or email or right now at the meeting. And I again thank you so much for giving me the time to speak.
Thank you, Dr. Kassab. We've mentioned earlier that we are not able to do a Q&A at this meeting, but we certainly welcome comments submitted to Palmetto GBA as part of the comment period. Thank you very much for your comments. Let's see, at this point, we are on our last speaker, Corey Greenblatt, a Senior Manager of Advocacy at Global Health Living Foundation. Corey Greenblatt? Oh,
yes,
there we
hello.
go.
Hello, everyone. Thank you so much. Thank you for the opportunity to provide comments today on the draft LCD. My name is Corey Greenblatt. I'm the Senior Manager of Policy and Advocacy with the Global Healthy Living Foundation. GHLF supports access to biomarker testing for our patient community to facilitate a faster connection between patients and medications that will best help them. By way of background, our organization is a 501c3 nonprofit group that works to improve the quality of life for people with chronic disease, often focusing on those least able to advocate for themselves. Through our websites, social media channels, and conventional media, GHLF reaches more than 10 million chronically ill patients monthly in the United States in English and Spanish. Our patient community is often forced to try multiple different types of medications before finding the one that works best for them. Biomarker testing, such as PRISM-RA, is an important innovative step that can reduce this time and ensure that the most effective medications are in the hands of patients as soon as possible. Our sickest and most vulnerable members of our society rely on expensive therapies that insurers label as specialty drugs. These patients that use these types of drugs have incredibly complex disease profiles and often several comorbidities. Together with their physicians, they select very specific treatment options based on disease progression, disease activity, individual immunogenicity issues, lifestyle preferences, and associated out-of-pocket costs. Without biomarker testing, patients are commonly forced to try multiple different treatments or combinations of medications before finding the treatment plan that works best for them. This trial and error period often leads to debilitating symptoms and a reduced quality of life, while patients suffer ineffective medications. Precision medicine and biomarker testing offers a chance to minimize or entirely eliminate these steps and more quickly connect patients to their ultimate goal, finding a successful and sustainable treatment plan. Evidence shows that these types of tests have been successful in other fields of healthcare, such as cancer, and the CDC itself has a page promoting the benefits of precision medicine. We just hope to see these benefits passed on to our patient community as we look to reduce patient burdens and increase the likelihood of successful therapies. On behalf of those in our community looking for access to innovative tools that will improve their quality of life, we hope that you will revise your draft determination and allow rheumatoid arthritis patients to realize the benefits of precision medicine by providing coverage for PRISM-RA testing. Should you need to hear it from patients directly, we are ready to connect you with those who would benefit from these types of tests. Thank you very much for your time.
Thank you, Mr. Greenblatt. Okay, we have now concluded with our speaker presentations and comments. So we want to thank you all for your attention and the participation. We want to share that, you know, we appreciate these comments on the draft policy and the feedback regarding our evaluative process. We also want to once again apologize for the difficult audio issues we were having initially, but we have managed to conclude our program on time, our open meeting on time. And so with that, I want to go ahead and formally conclude the meeting. Thank you all and have a great rest of your afternoon.